we'll introduce our next speaker, who is Dr. Peiyin Hung, Associate Professor of Health Sciences, Policy and Management at the University of South Carolina. Dr. Hung is going to be presenting on state telehealth reimbursement policies and hybrid prenatal care in the United States, a study of national clinical cohort collaborative data. Pat, I'll turn things over to you.
Thank you, John. Great, let me try this one. All right, thank you so much. So, such a pleasure to be here for the first time in Ann Arbor and presenting on behalf of my team on some kind of preliminary results of our M3. So, John already shared the topic for today's talk. We're still trying to make this M3 results as robust as possible. Appreciate all of your feedback after today's talk. All right, I just want to highlight and thank my team for this U01 project. We're finishing up our year 3, and we have 2 more years to go. So today's talk is gonna really focusing on M3. My mentor and my MPI, Dr. Xiaomindi, is here with us, and a lot of my team and my students are sitting in the audience, and we have 6 of us representing USC. This is it has been really a pleasure to be part of the consortium, especially the coordinating centers team, help us to be as productive as possible. We also want to thank our founder, NICHD, for this U01. All right, so you all have seen this in the past 2 years. So our first aim in our first presentation, actually, we had documented the negative impact on the COVID-19 pandemic on prenatal and postpartum care access, as well as severe maternal morbidity and mortality outcomes. So that's negative sign for M1. M2, we also documented last year. I presented the telehealth uptake that really improved the access to prenatal and postpartum care in terms of the timely initiation and the frequency visits. Then M3, we're really elucidating the impact or kind of associations between the state telehealth policies for different kind of telehealth modality on the telehealth uptake, as well as this with subsequent changes in terms of prenatal and postpartum access. Then M4, we're going to simulate this. How would this telehealth uptake in the system going to change the expenditures, access to care in the population? For example, from 10% to 20% of birthing individuals using telehealth, how would the outcomes change in the system level? So it's kind of well known that COVID-19 pandemic actually had disruptions in prenatal and postpartum care initiation timeless and the frequency visits. Using a national data from 2016 to 2022, prior work actually documented COVID in the early COVID, especially during March to May 2020, there were the COVID pandemic associated with reduced prenatal care visits and postpartum care visits. So you can see in this kind of reduced at the dash line. You can also see the delay, that more likely to have a delayed prenatal care initiation. All of these are going to be associated with delayed for detection for risk factors and higher likelihood of non-necessary cesarean deliveries, and more likely to have hemorrhage during their intrapartum care as well as postpartum care. So another thing is that you can see after the immediate increase reduce, there were some kind of backwards for the access to care for both prenatal and postpartum care. So we're thinking about, yes, telehealth probably play an important role in picking up those kind of disruptions during the early COVID. as we can see, telehealth uptake from last year's presentation, telehealth uptake really skyrocketed high after April and after May 2020. There are so many opportunities that telehealth can really improve access to prenatal and postpartum care, from mental health consultations, from asynchronous provider consultations for different kind of risk factors, to change the lifestyle. So for example, during pregnancy, for people who really have potential for gestational diabetes or pregnancy-induced hypertension. There are so many different kind of modalities, either from the patient portal, asynchronous, by the remote patient monitoring, or the live video consultations. Our N2 again show that you can see in the, so basically this is postpartum, the timeliness to get the first postpartum care after childbirth discharge. The red curve are those that were never used in telehealth. They only exclusively used in person, and they were delayed. They have much slower initiation for postpartum care. They have much lower postpartum care uptake after 1 year follow-up. And the green curve were those moms, they had telehealth for the very first postpartum care visits. The blue curve were those moms, they had used telehealth, but they actually started with in-person telehealth visits, followed by telehealth for the follow-up. And you can see telehealth users, regardless of the sequence, they actually have much quicker postpartum care initiation and much higher postpartum care initiation after 1 year follow-up. So this actually tells us telehealth users had abilities to really have earlier postpartum care initiation. That's gonna save a lot of deaths because of the early detection for risk factors, for really have a timely management for those moms, especially high-risk moms. But this is overall. Even though we know telehealth had that kind of benefits to some degree, we don't have a causal ability to do really causal conclusion, but you can see telehealth has some kind of correlations with the access to care. But then we still see only 10%, even in the urban settings, only 10% moms on average using telehealth. Don't even mention rural moms, they were less likely to use. There was a huge gap between urban and rural moms based on our earlier work from M1. So this is kind of a raising concern that we're seeing not really kind of max out the benefits of telehealth for the perinatal care. So next question is, right, we know the potential impact for pandemic, we know the potential impact for the telehealth, then whether state telehealth policies kind of moderate this kind of impacts. So today I'm gonna share with you, just focus on this in the interest of time. Hopefully I'm doing well. All right, so before we really look into elucidate kind of the understanding the state telehealth policy on the telehealth uptake for this birthing moms, we need to document. This takes our team 2 years to validate it because of the discrepancies across all the documents, are public available resources, legislation documents. So at the end of this February, we finally were able to get all the discrepancies solved by asking Medicaid agencies for those 13 states. We didn't really know which resources were really reliable. So you can see here, live videos were increasing, and after 2020, all the states reimbursed live video for perinatal care. But audio only, not starting until 2020, the public health emergency. For remote patient monitoring, you can see the rate curve is actually increasing over time. There were 2 states they had actually terminated audio-only reimbursements after 2023. In terms of the asynchronous, store and forward the patient portal modality. Only 28 states actually had that after 2020, and that has been consistent. In 2023, you can see all the states have video, live video reimbursement, and audio only for 43 states, and asynchronous patient portal. That's only about 28 states. And then mostly the cluster on the West Coast and on the North for the remote patient monitoring reimbursements. So that really gave us some abilities to really understand the variation for state health policies, as well as the temporal changes that allow us to do interrupted time series and difference in difference to really understand the telehealth uptake impact. So the question is, for today's talk, is we're going to see whether there was immediate and sustained changes in terms of telehealth uptake for prenatal and postpartum care before and after the state implemented each of the telehealth modality. So including asynchronous, audio only, remote patient monitoring, and any of the three. We couldn't really do live video because all of the states or at the end actually had those. The same data set as I presented last year, just recapped, we used national COVID cohort collaborative data. In the future, it's going to be national clinical cohort collaborative, not only just case control for COVID patients. We did EHR phenotyping, so they harmonized the data. It's not only ICD, but also EHR nodes, and they allow us to really get very detailed diagnosis and procedures, as well as different kind of care settings and patient demographic characteristics. I won't go into detail for the cohort, but basically because we're really focusing on prenatal cohort and postpartum cohort, we constructed them separately. We don't want to lose patients. They don't have one for each. We kind of do that separately and then have the same exclusion. At the end, prenatal cohort will occur among 85 health systems, and postpartum cohort, prenatal cohort were among 75 health systems across 50 states. DC did not really provide all these residence county locations. And postpartum cohort were from 85 states. Not all the health hospitals are providing prenatal care, obviously. Outcomes will really only do dichotomous prenatal care via telehealth versus exclusive in person. None of our birthing people had only telehealth use for prenatal care. It's either hybrid or in person. The same idea for postpartum. The telehealth policy exposure, just one slide, took 2 years of our team's work. So we kind of, because of the period for prenatal during pregnancy and period for postpartum for 1 year, we have to really compare comparable birthing people. So we constructed policy exposure during pregnancy, policy exposure during the postpartum care, and see if those moms, they never exposed to the policy or never exposed to the pandemic, then how are they different? And what if the patients living in the states with telehealth policy, would that generous policy improve the telehealth uptake? So these are the covariates. As usual, we do the chi-square for bivariate. We also do the multivariable mixed effects logistic regression because of the nature of our outcomes of interest. Difference in difference to really understand the immediate change, the shock change undertreated, and then use the states they don't have policies. Moms living in a state without policies as a control. And then historical cohort as the other control for the difference in difference. Here you can see it's kind of counterintuitive for prenatal moms. The blue curve were those moms that living in the states without policy. The orange curves were those moms that living in the states with policies. So prenatal cohort, you can see is higher among moms the telehealth uptake for prenatal care were higher among moms living in the states without the asynchronous reimbursement policy. That's counterintuitive. But this is driven by those clinical factors. So that's kind of when we control for a lot, 18, all these different covariates, this is kind of washed out, and I can show you at the end. It really depends on the policy. So you can see orange became much higher for prenatal and postpartum in terms of telehealth uptake. When we are looking at the audio-only reimbursement policies. For remote patient monitoring, that even make it stronger because of benefits, the well-known benefits and perceived benefits for remote patient monitoring, especially for pregnancy cohort. So after doing the difference, you can see this is kind of sharp increase on the treated, on the moms, this is adjusted odds ratio. For like people had full exposed to the policies, for pandemic actually have much higher, tenfold higher odds of telehealth policies, and that kind of trend was sustainable. It's kind of slowly increasing, but it's kind of very stable after the shock increase within the month of the birth of the labor and delivery. The same idea for postpartum care telehealth uptake. So the conclusion is actually very simple, straightforward. State telehealth policies have some kind of association with the increased hybrid care for both prenatal and postpartum care. And there is a potential, right? General reimbursements have some kind of potential to change both provider and birthing people's healthcare delivery options. But there are some other limitations for this data. There are so many limitations for this data to look into the telehealth uptake for birthing people, because we rely on EHR data. And this EHR data, we have to only extract those moms they had used prenatal or postpartum care. Because if they did not, they are not in our EHR data. It's not like Medicaid data, 100%, we can have eligibility criteria and track who did not use prenatal or postpartum care. And that was our aim too. We actually can do that. But M3, we have to do multiple states to really understand the variation for the telehealth policies and the variation for telehealth uptake. More importantly, we didn't really specify this telehealth uptake was for asynchronous, or this telehealth uptake is for audio only. We'll kind of lump them together and try to really understand in general whether the state telehealth policy for different kind of modalities have kind of spillover effects for overall telehealth uptake. There are some other information here. I would love to go in detail, but I am out of time. But after this M3, we're going to do more in terms of simulations and doing more for the causal conclusion with the different kind of state telehealth policies, maybe beyond the M3C EHR data, but leverage the national Medicaid data to really look into Medicaid beneficiaries' telehealth uptake that allow us to compare across states. So that concludes my presentation. I welcome any questions you may have later. Thanks.